Hi, this is Brian Kim. I'm going to share with you this case of a patient was referred to me from out of town. This patient had a complicated cataract surgery and the lens removal went fine, but there was significant zonular dehiscence and the surgeon didn't feel comfortable placing a lens within the bag. And so the patient is referred for secondary IOL placement. And so you're going to see the fact that there's actually pretty good posterior capsule support. And I'm actually going to take advantage of that and keep the posterior capsule in the bag in place and then perform the trailing haptic first modified Yamane technique. And so you can see there's the zonular dehiscence inferiorly. You can see the bag is basically shriveled up. I'm making my incisions for the externalization of the leading haptic. And this is the incision for the AC maintainer. I'm indenting the sclera for the trocar. You can see there's a nice mark indenting the sclera. And using the cotton tip to control the eye, I start around 2.5 to 3 millimeters adjacent to that mark, tunnel through the sclera, and then dive down and enter. You can see that the trocar is tilted, which is a good sign that the trocar has a nice scleral shelf and will allow me to have a self-sealing trocar incision. So I'm going ahead and placing my ink marks. You can see this patient is sleeping. I do these cases under block. And so, this patient's moving quite a bit with their breathing. And it's a little bit of a challenge, but we'll be able to get through the case. So I found 180 degrees apart using the cannula, and then I marked it at the limbus. And then I'm using the caliper to mark 2.5 millimeters posterior to that initial limbal mark in radial fashion. Yeah, because of the movements of the patient, it's a little bit of a challenge to make those marks, but I was able to do it okay here. So again, 2.5 millimeters back. Oh, and see the patient moves, so I had to make another mark there and kind of have to time it with placing the marks with the patient's movements here. So I'm bending my needle. This is the right side needle, bending about 9 millimeters posterior to the tip of the needle, making sure that the bevel is going to face the approach of the haptic. I always have the needle more central within the pupil so that the curve of the haptic is facing the needle. And this is the left side needle, and I bend it at the hub. So that's some dispersive viscoelastic to coat the corneal endothelium. And then this is the 3 millimeter blade, so I can place the IOL through that incision. Again, I'm sitting supertemporal, so this is a right eye. So this is an old case, just to be clear here. So that's why I'm actually externalizing the leading haptic with microforceps. Again, I don't do it this way now. I use a 25 gauge needle docking technique now, but this is a C2 Lucia lens, and so I do feel comfortable externalizing the leading haptic with forceps. You can pinch the tip of the forceps here and it won't really damage it here on the haptic. I'm delivering the optic now, making sure it comes out correctly. And I'm being mindful of that leading haptic is kind of turning a little bit in a funny way. So now it's coming out correctly. And the trailing haptic is pointed to the right. Pushing some more viscoelastic to protect the corneal endothelium. Placing my AC maintainer. And again, in this situation, the patient did have a vitrectomy, but I have everything ready just to be on the safe side. And back then I was doing this U-shaped configuration of the incision here with the haptic, but I don't do that anymore. And so I don't really feel like you have to do that, but I did in this case. Again, this is an older case. So you can see I'm making sure that I'm above the capsular bag plane. You can see I'm able to very carefully and confidently dock the haptic on the bevel of the needle, flatten it out, and I'm able to cannulate that needle quite easily. I disengage the syringe from the needle, internalize the leading haptic with the microforceps, grabbing the incision In order to keep the eye in the neutral position, I'm tunneling through the sclera from the first mark to the second, and then diving down, making sure I dive straight back, and then I roll my needle so that it comes into view. I want to make sure that I don't hit the ciliary body. Here I'm grabbing a little bit further back than I normally do, but because of the docking maneuver, even though I have to re-grab, I feel confident it'll be able to stay on the bevel, which it did here. I'm rotating the needle just slightly with my hand in the left hand, and the bevel was able to dock more effectively here, and so it slid right in. I'm externalizing the left side. I'm pulling down and then using the microforceps to make sure that not too much of the haptic comes out, and then I cauterize the tip and then perform the same maneuver on the other side. As I'm pulling out with the right hand, I'm having the left hand ready to go with the forceps right in place so that it doesn't slip back in. Slowly withdrawing the needle and then grasping the haptic very carefully and then cauterizing the tip. And then I'm pushing the haptic flush to the sclera. By pushing it flush to the sclera, it shouldn't be sticking up and the risk of erosion should be very low. Knock on wood, but I have not had a situation of erosion of the bulb or infection. So I'm doing some more vitrectomy, removing the anterior vitreous at the level of the posterior capsule. You can see again the posterior capsule is intact. Obviously it's wrinkled up inferiorly because of the zonular problems. And this is my vitrector assisted PI. Again, the cut rate is 30 fixed and aspiration is linear control to 12 and high vacuum. You can get really nice peripheral, well-controlled sized and located PI here. And you can see it's a really small, tight little PI. I use 6x speed and just showing the anterior vitrectomy through the limbal incision, removing any potential vitreous, but there wasn't any, but primarily to remove the viscoelastic. And then I'm hydrating the incisions. I pulled the trocar out, massaging the sclerotomy, and again, because the trocar was sitting tilted, this should mean that this is a nice self-sealing sclerotomy, which it is. And then I go ahead and place the suture through the main incision. I always do this when you're dealing with cases where there's potential vitreous. I bury the knot. I'll take the AC maintainer out. I'm feeling the eye, it's nice and pressurized. I don't see any leakage at all. Take the AC maintainer out and I hydrate my incision. So again, this is a patient who had a complicated cataract surgery. There was significant zonular disease and dehiscence. As a result, I performed the Yamane technique as well as peripheral iridectomy. I used the C2 Lucia 602 lens. I was able to maintain and keep the posterior capsule as well as the zonular apparatus intact. I placed the Yamane lens in place. And by doing it this way, I do feel like it provides more support of the haptics and the optic. And this patient, interestingly enough, ended up with 20/25 uncorrected vision. So this patient had an excellent refractive outcome. I do feel by maintaining and keeping the zonules and the posterior capsule in this situation, it does provide some additional support and just a belt and suspenders way of making sure that that lens is going to sit nice and planar. I think it does reduce the risk for tilt. But as you could see, I was able to execute the surgery, holding the eye in the neutral position, making sure the conjunctival marks reflect the intended scleral marks that I made. And you see a nice scleral shelf because the lens is sitting flat. You saw when I pulled the haptics out, they were nice and flat to the eye. If it's pointing up to the sky, that means the haptic is vertical. Therefore, that means the optic will also be vertical. That is a telltale sign that you have a bad lens position. And so if that happens, you have to redock and place it again. Again, that scleral shelf is so important when you're doing the Yamane technique. So I hope this was helpful to you, and I thank you for your attention.